The U.S. population is aging rapidly, creating serious challenges for our healthcare system. Yet most people don't think about end of life care until it's too late. Because of that, most individuals die in hospitals or nursing homes without their preferences ever being acknowledged. Part of the issue is how healthcare professionals are trained. The focus is on treating symptoms and curing disease. Asking about end of life wishes often gets overlooked. In medical culture, curing illness is seen as a win, while not curing is seen as a loss. This mindset discourages open conversations about dying. Another factor is the role of money. An estimated 27.4% of Medicare spending happens in the last year of life. Much of it goes toward aggressive interventions that may not align with the patient's values. In many cases, these treatments prolong suffering rather than improve quality of life. Culturally, Americans often view illness as an enemy to defeat. We resist the idea of inevitable death and tend to avoid discussing it. This denial happens at every level, personal, family, and policy, and contributes to the injustices experienced by people nearing the end of life. A big reason for this is that our healthcare system still relies heavily on the biomedical model. This model looks mainly at medical symptoms and treatments. It doesn't fully address the social, emotional, or structural factors that influence health and well-being. It became dominant in the early 20th century during a time of scientific and medical breakthroughs. Before that shift, death was often talked about more openly, but with the rise of modern medicine, patients came to be seen through the lens of diagnoses and treatment plans. When an illness couldn't be cured, it was often treated as outside the scope of care. Conversations about death became rare. This leads to a key question. Why has humanity been removed from end-of-life care? To answer that, we need to look at ableism. Ableism is the belief that physical, mental, and emotional independence is the norm, and anything outside of that is seen as flawed. In this worldview, people who are dependent, such as those near the end of life, are often marginalized. Western societies tend to promote independence and productivity as ideal. That can make people who need care feel like a burden. These beliefs can be internalized, reinforcing feelings of worthlessness. Ableism is more than a personal bias. It's a structural problem. It creates systems that value only those who meet certain standards of normal functioning, while ignoring others. That includes the elderly, disabled, and seriously ill. Challenging ableism is essential if we want a more just and humane society. There has been some progress. After World War II, fields like psychiatry, psychology, nursing, and social work began to push back against the cultural silence around death. They promoted the idea of treating the whole person, not just medically, but emotionally, socially, and spiritually. This laid the groundwork for hospice and palliative care, which emerged in the 1960s. These approaches prioritize comfort and dignity at the end of life. By the 1990s, these services became more available and public awareness grew. But despite their benefits, hospice and palliative care are still underutilized, largely because the biomedical model and ableist thinking still dominate our system. Another key issue is economic injustice in healthcare. Our system rewards costly interventions over person-centered care. The financial incentives push procedures, not hospice and palliative care. To address these challenges, we can turn to critical disability theory. This framework sees disability not as a medical condition, but as a social construct. Power structures define what's normal and pathologize those who don't meet that definition, including people at the end of life. Critical disability theory emphasizes dignity, equality, and inclusion. It reminds us that all people are vulnerable and interdependent, and that these qualities are not weaknesses, but part of being human. Using this framework, here are 3 key solutions for improving end-of-life care. First, we need to normalize conversations about end-of-life care in primary care settings. Primary care providers are often the ones patients see the most. That makes them well positioned to initiate these conversations early and consistently. I propose requiring an annual 30 to 45-minute discussion for individuals with serious illnesses. These conversations should be led by trained providers with prescriptive authority. The goal is to ensure patients' preferences are documented well before a crisis. Second, we must raise public awareness about the need for caregiving support. As people live longer with serious illness, caregiving needs are growing, but we face a severe shortage, partly because caregiving services are poorly reimbursed or not covered at all by many insurance programs. I recommend a federal mandate requiring all insurers to cover caregiving services. Reimbursement rates for care help should increase by at least 20% to better support and retain caregivers. It's also important to recognize that immigrants provide a large percentage of the caregiving workforce in the United States. Restrictive immigration policies put that workforce at risk. A national campaign should advocate for flexible policies that allow caregivers to live and work here safely and legally. Third, we should promote universal design in our communities and policies. Universal design is a concept that promotes systems and environments that serve everyone, regardless of age, ability, or health condition. It's not about special accommodations. It's about building a world that includes all of us, not as a privilege, but as a right. When we embrace universal design, we shift cultural attitudes at every level, from individuals to institutions, and we move closer to a society that respects and supports people at all ages of life, including the end. To summarize, the problems in end-of-life care are rooted in profit-driven healthcare, ableist values, and a narrow biomedical focus. But by using critical disability theory as a guide, by implementing practical, system-wide changes, we can build a more compassionate, inclusive, and just approach to care at the end of life.